approach in Okay, so we're taking a different approach today in our echo session, and this is because we are commemorating World Stroke Day, which takes place always on the 29th of October. So why are we now bringing this to you? Today we're going to talk about the multidisciplinary and cross-sector collaboration. In stroke management and just in any neurology approach, as you'll be able to see from the other sessions that we're having, you'll be able to see the importance of the multidisciplinary team approach in the care of stroke and just other neurological conditions. So I'm your presenter today, and I'm also facilitating because it's going to just be a brief thing. And my name is Malango Goma. I'm one of the first ever trained stroke nurses working at the University Teaching Hospital, and I manage the male ward. Okay, so we'll go back and just talk about how we started the stroke unit launch. This started in the month of October 2023, just here at the University Teaching Hospital. And there was an accurate, actually, selection of 30 stroke nurses. This was from the male medical ward as well as the female medical ward. Those of you who've had an opportunity of coming through to the University Teaching Hospital, you know E-Block. So we got some nurses from EO1 as well as EO2. So apart just from the stroke nurses that we have, we also have physiotherapists who've been trained in care of stroke patients. We also have nutritionists. We also have the social welfare and a lot of people, the lab, the pharmacists also, who've just been designated for the management of acute stroke patients. And what this did, it marked a significant milestone in enhancing the quality of care for stroke patients. Okay, like earlier alluded to, where 30 selected nurses were done in those two wards that I mentioned, EO1 and EO2. And those are the neurology wards. So internal medicine has categorized them according to conditions that are nursed on each ward. So EO1, EO2, we take care of cardiology, neurology, and hematology patients. That's the ground floor for the E-Block. Okay, so the training now of these stroke nurses. So after the introduction, before the stroke unit was formed, there was a massive rise in the mortality as well as the morbidity rates of stroke patients. So before the stroke unit, the death rates that we had was 24% of every admission of stroke patients would have 24% mortality rate. But from that time up to today, there's been a massive decline. We are recording less than 9%. So it's been reduced from 24% to 9%, which is actually a very good thing. And we're talking about result-based, evidence. So this also has improved in patient outcomes. A long time ago, we never knew that caring for these patients actually helps also on the outcome. There's always a notion, there's always a mantra that we always say when it comes to stroke and even just any neurology assessment. We always talk about time is brain. So we always teach the public out there when they see notable signs that are leading to stroke, they have to make sure that they come as quickly as possible. As it is right now, there's another session where their neurologists are taking part in, and they're introducing them on how to go about the TPA, because we now have to start dealing with that for the patients who come here, and that the onset of stroke should be 4 hours or less so that they can help improve the quality of stroke survival. And also, as I've talked about, the most notable achievement is reduction in mortality, as well as the complications that arise with stroke, where we have a reduction in decubitus ulcer formation, we have a reduction in aspiration pneumonia, and also the long staying hours and long staying days that people used to have when they come to the hospital. It's actually now reduced because we are preparing people for discharge upon admission. Imagine when a patient is just being brought there, we are involving the family members. We have to teach them on how to go about caring for the patients. We do a bedside mobility assessment too. We also have a UTH swallow screener. Most of us where we're working from, even in our training, there are times where we were not taught on how best we can go about doing a swallow assessment. But the people that we had sat down and came up with a tool that we use. They derived it from the Yale, and then we adopted and added other things that we're using here at the University Teaching Hospital. So there's also notably great reduction in stroke complications. So like I earlier said, we have a marked decrease in aspiration pneumonia. So a long time ago, the 24% of the mortalities I was talking about, 94% of those deaths were actually related to aspiration pneumonia. But as it is right now, there are months where we even record 0% of aspiration pneumonia. It's because of that skill that we were trained on the positioning of the patient, doing the swallow screener and all those things. Then we also have a reduction in DVTs, the deep vein thrombosis, because we are now trying to improve when it comes to mobility assessment. We know which level the patient will be at so that we can prescribe which mobility or which exercise should be done. So I must make mention that it's not only the physiotherapists who do the exercises, but even as stroke nurses, we are trained also to do that and just to help the patient so that we can prevent the DVT and promote mobility. That is improving the daily activities of living and just promoting recovery. Also, decubitus ulcer formation, because, even before the stroke, we used to tend patients 2 hourly, but then there are proper techniques that we're supposed to apply whenever we are tending the patients, okay? So it's not only the decubitus ulcers that we're preventing, there's also what is known as subluxation, because sometimes we used to use the inappropriate techniques where maybe you are pulling using the patient's hand, and then the shoulder joints can come out of the socket and cause the subluxation. So we've been skilled enough to be taught that, okay, as you are attending this patient, you always have to support the affected arm. If you don't have an arm sling, you can utilize whatever you have. Like here in Zambia, we use chitenges or even a bed sheet or even just rolling the hand in a shed. All right. So the improvements that we have been driven by consistent application of stroke protocols. So there's a stroke protocol that we have, a master stroke protocol guideline, which is a small booklet. It will show you on how you have to approach. For example, in ischemic stroke, patients are supposed to have permissive hypertension. A long time when you just receive a patient who's got a stroke, the first thing that you think of is, okay, the BP is too high. Let us normalize this BP. But after that intense learning, we've learned now that you're supposed to allow BP to be high because you're promoting blood circulation to the affected part of the brain, therefore enhancing what we call neuroplasticity, because we know that there's enough oxygenated blood that is going towards that affected area. And then early detection of complications. So when a patient comes, it's easier for us to detect the complications. Why? Because we've been skilled. So it's important for other people who are out there to join these echo sessions. It's through this that you're going to learn about how you can, detect complications. That is this patient going to be prone to contractures? Is the gait going to be okay? Is the speech going to be slurred and all those things? So such complications, when a patient comes, it's easier for us to actually detect and offer the multidisciplinary team approach that I talked about. Do they need to see a speech therapist? Do they need to see a nutritionist? What sort of diet are they supposed to take? And then it has also improved on the high standards of nursing care. In the stroke units that we have designated stationery that we use, which is different from the other units. So because of that, it helps you to note any deviation from normal in the care of this patient. And it also helps the nurses, the psychologists, the neurologists to know if the patient is slipping into depression, because that is one of the greatest complications that these patients with stroke always have. So we are going to talk about aspiration prevention, because I talked about it saying that it's one of the parameters that we reduced. So how have we achieved this and what is it? So aspiration pneumonia, is a common and a serious complication in stroke patients, especially those with dysphagia. I must make mention that every patient who has stroke, even if they're talking, you need to do the swallow screener on them, because you'll find that maybe the muscles that help us with swallowing reflexes, they might be affected because of the stroke. So you need to do the swallow assessment. We have patients who are talking, but they are on nasogastric tube feeding. Why? Because they had to fail the swallow screener. Until they are cleared that they are not at risk of having this aspiration pneumonia, then you can give them the other feeding options. So the stroke unit at the University Teaching Hospital here in Lusaka has prioritized this risk. It is actually one of the greatest morbidities that we are having when it came to stroke patients. And since October 2023, the unit has implemented structured nursing protocols, targeted clinical interventions, and these efforts have led to a notable reduction in aspiration prevention. So what usually we do, every stroke patient is not supposed to lie flat. The head end of the bed always has to be elevated. It has to be at 35 to 45 degrees always. So if you do not have the cardiac beds, the ones where you can actually prop up the head end of the bed, here at the University Teaching Hospital, we had to improvise where they had to make wedges. And we always place them behind the patient's back, just on the head end of the bed, so that they are always elevated. I know most patients complain of it's too much of them being propped up, but it's beneficial to them as it prevents aspiration pneumonia. How about this UTH swallow screener that I've been talking about? Well, this is just a tool that we use, the same way that you've seen a Glasgow coma chart, the same way that you've seen maybe a TPRR chart. Even this UTH swallow screener, we have a form where you have to ask the first 6 questions and then you do the last 3 parts. So you need to check if the patient has a tracheostomy, if the patient has had dysphagia before that stroke that they've had, and are they able to remain alert? I know you can't do a swallow screener on somebody who's obtundant or stuporous, or they are just drowsy because of certain drugs that they've taken, or just because of the stroke, depending on the affected area. So this tool, we use it for early identification of dysphagia. It's very crucial because it helps prevent aspiration pneumonia. So upon admission, we always administer this tool. All stroke patients are screened within the first few hours. And you have to observe, because there are others who might fail the swallow screener today, but make sure you repeat it within 48 to 72 hours. And trained stroke nurses perform the swallow screening. So it's not only the stroke nurses who can perform, even the stroke registrars that we have. And we've been trying to lobby that we can teach this to the student nurses out there, because all of us who are just taught perform a swallow screen, you don't even know how to go about step by step. That is why we've brought it to you where you are, as close as possible, through this echo session that we're having. So make sure that the screening is done before any food, fluids, or oral medication are given to this patient. Like I said, just because somebody is talking and they have a stroke does not mean that they cannot have dysphagia. So you have to prove it by administering the swallow screener to them. And then it ensures that safe feeding decisions are done timely and done a very timely intervention. So apart from this swallow screener that we usually use as nurses, we just use 90 ml of water, where we have to give the patient to take. And if they stop before they finish that water, it means they have failed. We do not just stop there and rush to put up a nasogastric tube. No. This is where now the stroke registrars will come in and perform what is known as a ZGAS, which is just a Zambian gagging swallowing screener. So this one, they will use now different textures of fluids. We have a thickener that we use, which is called Thicket, but in areas where you don't have this thickener, you can utilize the textures that we've already put there. For example, it has to be honey thick, nectar thick, or very thick. So it's 3 kind of thicknesses. So if the patient failed to take water, then you're going to go to nectar thick. This is where you talk about things like maybe Fruticana guava, because it's kind of thicker than water. Same applies with Fruticana mango. That one is called nectar thick. So if a patient also fails that one, then you can go to honey thick, something that is dropping like the porridge that we take and all those things. If the patient fails that, then you can try another texture which is more thicker than that. If they pass, then that is what you're going to prescribe. Meaning this patient failed to take water, do not give fluids which are as thin as water, very fine fluids like water, because they are going to be predisposed to aspiration pneumonia. I talked about the head of bed elevation. So all stroke patients are nursed in a propped up position, which aims to prevent the aspiration pneumonia. So as it is in the stroke unit, we now have cardiac beds. So before the cardiac beds that we had, we were using designed wedges for proper positioning, which was just helping and all that. Then we also have the use of alternative feeding methods. So remember, the only one that most people will talk about is no, the patient failed to take water, so let me insert a nasogastric tube. So you have to coordinate. Remember, we are talking about the importance of multidisciplinary team approach when it comes to the care of stroke patients, okay? So patients with severe swallowing difficulties, the nurse has to coordinate with the medical team for safe nutrition plans. So you need to consult the nutritionist also on the available feeding options depending on the other underlying condition. For example, we talked about hypertension being the leading cause of strokes that we have globally. And then there's also diabetes mellitus. We also have hypercholesteremia. So all those things, the neurologist has to consult with the nutritionist so that we know the available feeding options that we have. If the patient is going to be taking parenteral feeds, or if the patient is going to take feeds through the nasogastric tube, which type of foods are they supposed to take? So that is why it's important to have the MDT. And then you have to initiate NG tube feeding whenever necessary. If the patient has failed everything, then you can put up a nasogastric tube because even nutritional wise, you are helping this patient recover because you're giving them foods that are rich in proteins, vitamins, and all those things. And it will also help with adequate nutrition and hydration. And it's also helping compromised swallowing. So, after you've successfully inserted the nasogastric tube, you are preventing aspiration pneumonia because the food content is going to be going directly in the stomach. And as you are doing the NGT placement, you have to make sure that you have to carefully place it because there are times that other people have punctured the patient's lungs because the tube had to go there. And here's someone who's busy feeding who can't even check if the nasogastric tube is actually in the stomach or it's in the lungs. So it's very important. If you are not competent, call for an assistant to come and place it. Yes, so that is the importance of the use of alternative feeding methods. Then oral hygiene maintenance. Every patient who's on a nasogastric tube should actually also have oral hygiene done. Initially, what is supposed to be done is after every feed, oral care should be done. But then we're talking about understaffing. So at least 3 or 2 times a day, the patient's mouth has to be cleaned because the mouth becomes a very good area for bacterial growth. So here's somebody whose swallowing reflexes are altered. And then once they swallow that saliva, instead of it going in the stomach, maybe it slips and goes into the lungs. It can be a good medium for bacterial growth. So poor oral hygiene increases pneumonia risk due to bacterial aspiration, like I have explained. So nurses at UTH stroke units ensure strict oral care, especially for the new oral patients, patients on tube feeding, and it's just a routine where we have to brush the teeth and the gums with soft brushes. If you do not have the soft brushes, you can actually improvise where you can use the orange sticks. If you don't have the orange sticks, then you can use the tongue depressants, you cut them properly and just tie some gauze or some cotton wool, and then you can clean using normal saline. And you can use also some oral antiseptic solution apart from normal saline. There's also povidone, which can be used for oral, not the povidone, the one that we use for wound cleaning. There's one which is specifically designed just for the oral cavity. And suctioning of oral secretions, which is done PRN, that is whenever necessary, so that there are certain patients that you're going to have, stroke patients who are going to have the corpus oral secretions. So in order for you to prevent this aspiration pneumonia, you always have to make sure that you have a suction machine, and which we lobbied for. So every stroke unit has at least a suction machine. I talked about performing oral care every meal to reduce infection risk. So what do we do about monitoring and early detection? So on the photos that you're able to see, which is on my right, above there, there's a stroke nurse, one of the 30 first trained stroke nurses. And then by the bottom there, when you come to the ward, there's always a poster that is there to show you that you're now entering a stroke unit for the male ward or the female ward. Okay, so monitoring and early detection. Nurses are trained to identify the early signs of aspiration, which is coughing during feeds, gargling sounds, the unexplained fevers, the changes in respiratory rate. And patients who are at a higher risk of such, there's always monitors that have been placed. So in the stroke unit for the male side, there are 6 beds, as well as the female side where we have 6 beds. So among those 6 beds, we have 3 beds from the male side and 3 beds from the female side where we have monitors and we connect them to the patients, those that really are critical or will need time to time monitoring and they need more care compared to the others. So we monitor them as such. And what does this early detection prompt? One, it's immediate clinical evaluation and timely intervention. So there's always a stroke registrar who's on duty that will always call and tell in case there are some changes that have been noted by the stroke nurses. Okay? And the patients that are at a high risk, they receive close monitoring. They have adjusted feeding protocols to enhance safety. So like I earlier mentioned about the close monitoring where we put them on monitors and just observe them. And for the feeding options, there are others maybe who might not be able to tolerate the 300 meals. If it's nasogastric tube feeding that you're giving at 3 hourly, you might reduce that. And that is where it is important to have the nutritionist so that we can see how much meals or how much feeding they need to take within 24 hours, and then you can divide that and give them accordingly. So education of caregivers and patients, like I earlier mentioned in the introduction, we always believe that involvement of relatives in the stroke ward is ideal. So we give the information, education, and communication that is part of health promotion. Immediately a patient comes in, you start preparing them for discharge. Why? Because we know that stroke is actually a debilitating kind of condition which takes time. Some of the people, maybe you might be able to see improvement in 3 months, others in a year. It depends on how the patient is and the age also. We have to factor in a lot of those factors in order for us to know how long maybe a patient should be coming and all those things. And then there are other times where we discharge patients to go home with a nasogastric tube. So we have to teach the bedsiders on how to feed and to check for any, danger signs, if there's any dislodging of the nasogastric tube and what they're supposed to do. So we have the nurses as well as the public health practitioners that we have under health promotions who provide targeted education. Even the stroke registrars, as they're attending to the patients, they always also start talking to them about preparation for discharge. So we talk to the relatives and the patients about safe feeding practices. There are notions out there when you're inserting a nasogastric tube, they always think that you're about to kill the patient. And when you're also putting up nasoprons, maybe the patient needs to get some oxygen, because any stroke patients with an SpO2 of 94% or less, we always give them some oxygen, which we follow in the master protocol, and we'll be glad to share with other people on our forum. Then also upright positioning during and after meals. We talked about how it can be very, inconveniencing for one to sleep in an upright position because they're supposed to be elevated and propped up between 35 and 45 degrees. Then there's also strict adherence to, the early signs of aspiration, where we talked about cough, fevers, and all those things. We tell them, when you notice this, please come back to the hospital so that we can see how best we can help you. Then there's also strict adherence to dietary recommendations. So depending on the swallow screener on how you did it, is it the ZGAS that you did? So there will be a dietary recommendation that you're going to give them, and they're supposed to adhere to this strictly. Most of the time, the nasogastric tube patients that we have around Zambia, the most common thing that they bring is super shake, which is not even good for the patients. So that is why it's important to involve the nutritionist so that they can prescribe the appropriate foodstuffs. Then the empowered caregivers are better equipped to prevent unsafe feeding practices, support patients after discharge. And, indeed, education has played a key role in reducing aspiration risks, both at home and on the ward. Everything that you're doing on the patient, if you're explaining to the relatives, they actually get to have a know-how of whatsoever is being done. That knowledge, they will grasp it and all that. So it's important that you start involving them from the time that the patient has been admitted. So what are some of the outcomes and the impacts that we've had so far when it comes to these stroke units that we've had? So we've got the reduced incidence of aspiration pneumonia in stroke patients. Like I said, there are times we even record 0% in a month. So like this year, the highest percentage we ever scored was 4%, reduced from the 94% of those mortality rates that we used to have and morbidities. And there's lower patient mortality rates, which has been observed. I talked about reducing it from 24%, we're below 9% as it is. Then there's also decreased length of hospital stay, because the moment the patient comes in, you've already started programming them on which mobility assessment they will be doing. Are they on level 1? Are they on level 2? Are they on level 3? So that as you are doing all those exercises, you are helping them recover quickly and maybe be sent home so that they can continue with the physio from home and just come here for their review dates. There's also reduced reliance on antibiotics when it comes to aspiration pneumonia prevention, which I'm sure the other sister echoes that we have, the ones that are talking about antimicrobial resistance, there was a time where they had to be that we started having a lot of antimicrobial resistance cases. But because of this, because of the skills that we've attained, the proper positioning of the patient, the swallow screener assessment that we're doing and all those things, we have reduced reliance on antibiotics. And then there are also fewer ICU admissions, because once one patient gets aspiration pneumonia, you need to take them to main ICU, others for possible tubation and all those things. And then the results that we have been driven by consistency and evidence-based nursing care that we've been given. And there's also structured prevention protocols, and we have a skilled and vigilant nursing team. So as it is, we've trained also stroke nurses at Levi Mwanawasa Medical University Teaching Hospital just here in Lusaka, as well as in Dola Teaching Hospital in the Copper Belt, same with Kitwe Teaching Hospitals. So Kitwe Teaching Hospital has even opened a designated stroke unit for them. Same applies with Ndola and also Levi Mwanawasa Medical University Teaching Hospital. So this is really helping, and it's actually helping us have a less flow of patients coming to the University Teaching Hospital. Thank you very much for your attention. And this is the brief topic that we had, just to tell you what we are doing with the stroke that we introduced. And, you know, because of this wonderful stroke units that we opened as the University Teaching Hospital, this is what we've been doing. And we are praying and hoping that people out there can also have designated stroke units in future when you train more neurologists. But as it is, this is where we are encouraging nurses also to join these eco sessions, because we're talking, remember, this is multidisciplinary team approach. So we need to have a lot of people coming on board. Let the nutritionists from the center where you are, from the province where you are, let them join so that they can get this information, they grasp it and pass it on to others. There, you can post questions in the WhatsApp group that we have if you have a patient that maybe might need the neurologist to give you an opinion and stuff, because we cannot allow the neurologist to leave the University Teaching Hospital and start coming maybe to as far as Luapula province or maybe Northern province. But there's always someone who's caring for someone who's got a stroke. So do join us tomorrow on the 29th of October. We'll be here at the University Teaching Hospital car park, where we're going to commemorate the World Stroke Day. So we're going to even have people who've survived strokes before. They will be there to give their testimonies, and there will be actually a lot of displays, so you can come and get more information that you need. If you are here within Lusaka, you are cordially invited. Thank you for having spared some time with me. If you have any questions based on the presentation, please feel free and ask questions. Any questions? You are free for comments, clarifications, and questions, or any other thing that you have concerning the presentation and the World Stroke Day. All right. If we do not have any questions, thank you very much for your time. And we've come to the end of the session. And please continue sharing with other people on this ICO and its importance wherever you are. Thank you for your time and see you tomorrow as you come to commemorate the World Stroke Day.